So my topic, I'm gonna share my screen, and then we're gonna start. Just let me share the screen. Okay.
Yes, we can see.
Okay, great. All right. So I'll be talking mainly about non-invasive management of acute respiratory failure, mainly with hypoxemia. Um, so So types of respiratory failure, as Talha mentioned, that in COVID-19, most commonly is from physiological shunt. And what physiological shunt is, basically part of the lung is consolidated, and that part of the lung is perfused, but there is no oxygenation or ventilation. So this is just like the blood is going from the right heart to the left heart, bypassing the lung. It's going through the lung, but the lung is not doing its job. So that is the most common way people get hypoxemia in COVID-19. The other ways they can get hypoxemia is from hypoxic vasoconstriction or microangiopathy or venous clots that can happen in some of the COVID patients. Hypoxemia can also happen from sepsis, which is basically increased tissue utilization of oxygen. Hypercarbia is not common in COVID-19 patient, but COVID-19 patient who have obstructive lung disease, especially COPD, or they have obesity hyperventilation syndrome, they will be hypercarbic. Patient who have been basically working pretty hard for hours and hours, they can become altered because the respiratory drive will go down. Ultimately, they'll get tired, and they will go into hypercarbia. Patients who are on sedatives like oxycodone, patients who get IV sedatives or narcotics, they can also go into hypercarbic respiratory failure because of decreased respiratory drive. A patient can have a mix of hypoxemia and hypercarbia. So what are the non-invasive systems of managing acute respiratory failure? So I'll touch on the basics of these systems, which include nasal cannula, ventimask, non-rebreather, high flow nasal cannula, CPAP, and BiPAP. So we'll first talk about the basics, what they are, what's their capacity, then we'll talk about their utilization in respiratory failure. So the choice between all these modes of support will depend on patient clinical status, their degree of hypoxemia, their respiratory distress or work of breathing, and presence or absence of hypercarbia. So regular nasal cannula, a standard nasal cannula, just remember it's a low flow nasal cannula. It usually cannot handle more than 6 liters per minute. So even if you dial the oxygen more than 6 liters on the wall, the size of the tubing is not big enough to handle usually more than 6 liters. So just remember, if someone has reached 6 liters per minute with a regular nasal cannula, even if you have dialed it to 10 liters or 15 liters, they're probably not getting more than 6 liters. There are intermediate nasal cannula where the tubing is a little bit bigger. Their tubing is similar tubing as like Ventimask or a non-rebreather. So those intermediate nasal cannula can handle up to 15 liter, 10 to 15 liter. So I'm not sure if every hospital in Pakistan do carry those bigger tubing, but it is worth asking the respiratory therapist when the patient is requiring more than 6 liter to see if they can be transitioned to intermediate nasal cannula, which can handle 10 to 15 liter. Ventimask, they fit loosely around the mouth. Some patients prefer mask more than nasal cannula, so it usually is a better option for those patients. Their flow rate is usually 6 to 10 liter. Their oxygen concentration is between 35 to 50%. Non-rebreather is actually, it can very reliably supply highest concentration of oxygen up to 90-95%, which is big. You know, a ventilator provides like 100%. So this non-rebreather can provide 95% FiO2, and their flow can be 10 to 15 liter per minute. With the non-rebreather, just make sure the mask is like not loosely fitting. Try to fit the mask well on the patient so that they can get maximum amount of oxygen. So if someone is on non-rebreather and they're still hypoxemic, that is bad. You know, that means that patient will probably need something, non-invasive or even mechanical ventilation. Next is high flow nasal cannula, and I'm not really sure. I'm sure that most of the government hospitals probably don't carry the high flow nasal cannula in Pakistan, and correct me if I am wrong. But some of the private hospitals can carry it. This is actually a great non-invasive mode of oxygenation, mainly in respiratory failure patient. Most of these patients can tolerate it pretty well, more better than the mask like CPAP or BiPAP. It can provide 100% FiO2. It can provide up to 60 to 70 liter per minute flow. And with a higher flow, it also provides some positive pressure, about 3 to 5 centimeters of water. The high flow nasal cannula is basically mainly for patients with hypoxemic respiratory failure. And we also use it in patients after post-extubation, but we're not talking about that. But the high flow nasal cannula is mainly for hypoxemic respiratory failure. It does not provide ventilation, but it can help people with the hypoxemia and respiratory distress. CPAP, I'm sure most of the people are aware about that. It provides continuous pressure. So during inspiration and expiration, it provides continuous pressure. This is similar to like PEEP on vent. And CPAP is mostly used in chronic settings like in obstructive sleep apnea, obesity hyperventilation, some of the patients with obesity hyperventilation syndrome. But in acute settings, CPAP can help with pulmonary edema, atelectasis, and workup breathing. So the basic mechanism is that it provides the continuous pressure. It tries to keep the lungs open, right? It tries to keep the lungs open. It prevents atelectasis, and it mainly helps with oxygenation. Again, because it's a continuous pressure, it does not really help a lot with improving tidal volume. But it is more helpful with patients who have like pulmonary edema, they have atelectasis, and it can help with some workup breathing. It can help with tachypnea by improving oxygenation. So usually, if someone is not on CPAP at home, you can start at a pressure of 5. Obese people who have big, they have thick chest wall, heavy chest wall, a big belly which is pressing on the diaphragm, they usually need a higher pressure. So in those people, I probably would start with like 8 or 10. If someone is on CPAP at home, you want to start with at least their home settings, whatever they are. And at home, if they're at a fixed pressure of, let's say, 12, you want to start with like 12 or 14 at least. If they are on an auto titration CPAP, you can start at a higher end of their auto titration CPAP pressure. And then is the bi-level positive airway pressure, which is commonly known as BiPAP. So the difference between CPAP and BiPAP is that the BiPAP provides inspiratory pressure and a separate expiratory pressure. So the difference between the inspiratory pressure and expiratory pressure determines the tidal volume. And this is mainly used for patients with hypercarbic respiratory failure, because you want to improve their ventilation by improving mainly their tidal volume. And just remember that we would not use BiPAP for patients who are obtunded or unable to breathe. So the patient needs to be breathing spontaneously, because this is not a ventilator. Although BiPAP has a backup rate, but the patient has to, for the most part, initiate breath. If the patient is not able to initiate breath, BiPAP probably would not be a great choice. Also, BiPAP and CPAP both, you don't want to use it in patients who are vomiting or have non-resolved small bowel obstruction or large bowel obstruction, because what they can do, they can have emesis into their mask, and that can all be pushed into their lungs, and they can go into severe aspiration-related respiratory failure on top of respiratory failure, whatever they were having. So just remember that. And I'll go into I'll touch more about the EPAP and IPAP in next couple of slides. So what you want to do is like when you put the people on the patients on BiPAP, the common mistake I see, they get put on BiPAP or whatever pressure, and then you basically don't evaluate how well it is working. So the reason we put people on BiPAP is that you want to improve their you want to improve their ventilation, mainly the tidal volume. So on BiPAP machine, there are two views. One view will tell you what the settings you set, the basic settings on BiPAP. The other will be the patient data. And you really want to look at the patient data and want to make sure the patient is drawing good tidal volumes, like 500, 600. If someone is drawing a tidal volume of 200, normal size person, 250 consistently, that means BiPAP is probably not working. You also want to make sure the patient has a tight seal of mask on his face that can be checked with, yeah, just a physical check. You can place your hand around the mask and you will know if there is a leak or not, because you will feel it. And then you can adjust the mask as tight as possible so there is no leak. Make sure there's a starting delta. If someone gets started on a BiPAP of 10/5 and they have severe hypercarbic respiratory failure, it probably won't work unless you can see the tidal volume. If they're drawing tidal volume of 500 or 10/5, great. Otherwise, you want to start like at 12/5, 14/5, something like that. Some people, just remember, some people don't tolerate a higher respiratory pressure. It's a lot of pressure. I'm not sure if any of you have tried BiPAP, but it is not the most comfortable thing in the world. But you want to give them a delta. Delta means the difference between IPAP and EPAP. So you want to give them delta of like 7 to 10 in order for them to draw good tidal volumes, and then just see how they do. Patients who have obstructive lung disease, mainly COPD, not asthma. COPD people usually require a very high delta. Usually, you want to start them at least on like 18/5 or 6, something like that. Give them a delta of 10 to 12 and give them a higher inspiratory pressure. And sometimes they even require 22, 24 over like 8, something like that. Usually an inspiratory pressure on BiPAP more than 22, 24 does not provide any additional benefit with ventilation. But COPD people, just remember, they usually require a very high delta. Um, so how do we choose between these modes? Before I go into that, I'm going to show you this one small slide of BiPAP. You can see, and there are different devices from different companies. This is from Respironics. You can see this. If you can see my arrows on the left side, this is what you have. This is the mode of BiPAP. This is the data that can be changed by you. And this will be on the right side, the patient data, what the patient is doing. So what you see here, that the IPAP is 12, EPAP is, let's say, 4. This patient has a delta of 8. And these are the two main things that you want to set. You can also set FiO2 on most of the BiPAP. You can set the backup rate of 10. But again, as I said, this is like, if someone is not spontaneous breathing, then they probably should not be on BiPAP. So backup rate usually does not matter in most of the patients. And then here on the right side is the most important thing. You can see at the rate patient is breathing at a rate of 31. So you want to follow that patient. And when you're starting the patient, their respiratory rate is 30, 31. And if BiPAP is working, their work of breathing will decrease. Their respiratory rate in, let's say, half an hour, 1 hour will come down to like 25, 24. It's working. That means it's working. But if in half an hour, 1 hour later, their respiratory rate is like 40, 45, it's not working. That patient probably needs mechanical ventilation. The other thing you want to look at is the tidal volume. That's the most important thing I have been talking about. This is like little blurred here, but this basically says the tidal volume is 203 ml, which is not great. So you want to look at the tidal volume. The tidal volume should be like anywhere like 400, 500 at least for hypercarbic respiratory failure. I'm not talking about hypoxemic here. BiPAP, again, just remember, is we're talking about hypercarbic respiratory failure. So you want to look at the tidal volume, make sure patient is drawing good tidal volume. So those are the two most important things on the patient data that you'll be looking at. You can also look at the air leak on the machine. And here, like it says 47 liters per minute, which is a lot of air leak. Usually, you should be usually less than like 10 liters per minute, ideally less than 5 liters per minute. So so this is like the basics of like what these devices are and what they do. But how do we choose between different systems? So usually patients who have mild acute respiratory failure with hypoxemia, you will start with nasal cannula or venti mask. Some patients prefer a mask than a cannula, but most of the people do fine a nasal cannula. And then, if they have reached like 6 liter, you want to increase that. You want to go to intermediate nasal cannula, or you want to go to initially venti mask, or you want to go to non-rebreather in those patients to provide higher FiO2. Because the in terms of the flow, venti mask will also provide the same flow, like 15 up to 15 liter as non-rebreather. But the non-rebreather will provide 95% FiO2, as opposed to venti mask, which provides, let's say, 50% at maximum FiO2. But just remember, if someone is with acute hypoxemic respiratory failure, is in respiratory distress, like if their respiratory rate is like more than 25 or more than 30, then that patient probably needs something more than those, non-rebreather. Non-rebreather may still work, but definitely more than nasal cannula or venti mask. Those patients will probably need like high flow nasal cannula or CPAP with a higher like 100% FiO2. And then once you start them on that, you want to follow them clinically, that how they are doing, like their workup breathing, if they are using accessory muscles, their tachypnea, their tachycardia, if they were agitated, their mentation, if that is improving or not. And then you want to follow them with maybe in some cases a blood gas, like if our saturation is more than 94% or even 92%, that is probably reliable. But if they're clinically doing great, that you probably even don't need a blood gas. But if they're not doing well, then you may consider an ABG to check their PO2 if their oxygen saturation is not reliable. Patients who have hypercarbia, you will start them with BiPAP. The patients who have acute hypercarbic respiratory failure or acute and chronic hypercarbic respiratory failure with who are spontaneously breathing. You will start them on BiPAP, then you will follow them clinically, that you will follow their respiratory rate, workup breathing, their tachycardia, their mentation, and then more important, as importantly, on the BiPAP, like the go tidal volumes, their respiratory rate on the BiPAP is getting better, their air leak is not there, and then you want to follow them with a blood gas. Usually a VBG, these patients who are started on BiPAP is mainly for hypercarbic respiratory failure. So the VBG is usually reliable. There's a difference of about 5 to 10 millimeter mercury of PCO2 between an ABG or VBG. The VBG is usually higher, and it's usually VBG is reliable for tracing the PCO2. But if you want to trace the PO2, in case the oxygen saturation waveform is not great on pulse oximetry, then you will need an ABG. But the other problem comes in patients with COVID-19. So patients with COVID-19, and my slides, actually, I'm going to stop my slides because they end here. But I want to talk about in COVID-19, how do these systems work differently? So can you bring the slide with the vent picture?
Top slides?
Some of top slides. So I want to just go through that a little bit in detail.
This one?
Yes, thank you. So just remember in ARDS, the thing that improves survival and reduces mortality, the most important thing is low tidal volume ventilation. So you have to understand this slide in order to understand the low tidal volume ventilation. You see on this slide on the left lower corner, there is F, which is respiratory rate. There's VT, which is tidal volume. And then on the right lower side, you see PEEP, which is set as 5. And above PEEP, you see O2, which is FiO2. So these are the four most important things are parameters that you will be setting on the ventilator, okay? F, VT, tidal volume. On the right side, FiO2, and the right lower side is PEEP. And what you want to do on the V tidal volume, that is the low, this is how you will set the low tidal volume ventilation. So you will try to calculate the ideal body weight of the patient based on gender and height. Those are the two things you will need. And then you will set a low tidal volume, which you will start with 6 cc per kg. And in some patients, you have to actually severe ARDS, gradually decrease it to 4 as well. But you will start at least 6, not more than 6. And for that, you will need a higher respiratory rate because you're decreasing the tidal volume. In order to achieve a minute ventilation, you'll have to increase the respiratory rate, usually around like 22, 24. But just remember, when you have set these settings, just look at the top line on this slide. So you have set the respiratory rate at 24, but this patient is breathing at a rate of 24. Okay, so that means the patient is breathing about at the same rate the ventilator is set. That means this patient is either heavily sedated or even paralyzed. Because most of the patients, just consider on yourself, if you're drawing in low tidal volume, you will feel uncomfortable. So the patient don't feel comfortable on low tidal volume, and then they try to take extra tidal volume, and then they try to breathe faster. And the ventilator has an auto flow. So the ventilator would, in most of the cases, the ventilator will allow them to take extra tidal volume and will allow them to breathe higher than the set respiratory rate. And if they're taking an extra tidal volume, then you're not, basically there's no tidal volume ventilation because you have set it on the ventilator, but they're taking, like if it is set as 500, they're taking 600, 700, then it is not working. So you want to look at the right corner, look at the right upper corner where it says VTE, expiratory tidal volume. It shows 522, which is great. You have set it at 500, so it's about there. So these patients, just remember, when they are trying an extra very higher tidal volume, let's say if they're trying 600, that means that patient first you will need to increase sedation. And once they're fully sedated, if they're still drawing higher tidal volumes, then you probably might even need paralysis for those patients in order to achieve the low tidal volume ventilation. Okay, so that's very important. And the second thing is, with low tidal volume ventilation, what you will get permissive hypercarbia, right? You're giving them low tidal volume. In ARTSNet protocol, they tolerated a pH of 715. But if you're not comfortable with a pH of 715, you can tolerate a pH of 720, 7.25, something like that. But as long as it is above 7.20, most of these patients will do well with the low tidal volume ventilation. I'm going to also show you the ARTSNet table that you will be using for these patients when they're on the ventilator. So Vikas, can you stop sharing your screens? I'm going to share my screen.
Sure.
So can you see my screen?
Yes.
Okay, great. So this is the ARTSNet table that you'll be using. So you can type it in Google, ARTSNet table. This will come up in the images. This is also available on artsnet.org on their website. So on the left side, you see the patient setup, and this is how you calculate the ideal body weight, like in male and female. What you need to do, you need to have their height, right? So for example, for let's calculate for a male of 5.5, 5 feet 5 inches tall. So what you will need, that patient, the initial 50 kg plus 2.3 kg per inches above 5 feet. So this patient will be 50 kg plus 2.3 multiplied by 5, which is 5 inches above 5 feet. That will be like, let's say 13. So this patient's ideal body weight will be somewhere around 63, and you will multiply that 63 to 6. That will give you the starting tidal volume. Okay, and then on the right side, what you see is the PEEP and FiO2 table, and you can see PEEP of 0.3 going all the way to 1. And there's two ways you can use. You can use lower PEEP, higher FiO2, or you can use higher PEEP, lower FiO2. In patients who have severe ARDS, those patients have very low compliance. Those patients usually require a higher PEEP. And then sometimes they require higher FiO2, sometimes they require a lower FiO2. But in patients who have relatively lower, higher compliance. You know, their lungs are not as bad. Actually, their X-ray looks bad, but their compliance is not as bad. So those patients many times can be managed with a lower PEEP of like around 10, something like that, and then sometimes they require higher FiO2. But you can use this table to basically help help change the FiO2 or PEEP and manage that patient. And so that will be, that's the basics about managing these patients. And then you see on this table on the right lower side, what you want to do, that it says if P plateau is more than 30, what you can do, you can decrease the tidal volume. If it is, let's say, at 6, you can decrease it to like 5 cc per kg. But if it is already, let's say, at 4 cc per kg, you don't want to decrease it below 4 cc per kg. If the P plateau is still high, then that patient has very severe ARDS, and there are other things that can be done. Sometimes changing the respiratory rate and sometimes paralyzing those patients. And if their P plateau, but your sweet spot for the P plateau is around 25. So if it is less than 25, especially if it is less than 20, you want to increase the PEEP to bring it close to 20, 25. So that is the table that you wanna
You can
use as
stop
your
sharing the
reference.
screen, and then
Uh,
we.
okay, so one of the thing I want to go back to my presentation. I'm going to stop sharing the screen, and I was trying to finish at what is the risk of aerosolization with the positive pressure ventilation. So just remember, there's a theoretical risk with the positive pressure ventilation, that it will generate aerosols, and in COVID-19 patient that can be risky, because if it generates aerosol, then people who are especially within the room within 6 feet distance can get infected if they're not using a fully fit N95, or if the patient is not in a negative pressure room. So if someone is on CPAP or someone is on BiPAP and they have COVID-19 pneumonia, you have to be very careful. In most of the institutions here in United States, they do not use positive pressure ventilation in COVID-19 patients, mainly because of the risk of aerosolization. And if someone is needing, let's say, more than 20 liters per minute on high flow nasal cannula, or if they are even needing more than 6 or 7, there will be a type of the patient who will have a sudden deterioration, and the most of the institution here is just going directly with the mechanical ventilation. But all patients don't need it, and again, it also depends on the resources. If someone is, let's say, on CPAP, and you have like full PPE, and that hospital does not carry mechanical ventilation, that patient still should get CPAP or BiPAP, as long as the people who are going to healthcare provider who are going to care for the patients are fully protected. So just keep that in mind. There's a question about the L type and H type on ARDS in COVID-19 patients. I'm going to touch that question because we're already talking about ARDS. So there was this article, and most of the people had read low L type means low compliance, and H type means high compliance. So uh, I would say this is not like just in COVID-19 related ARDS. So ARDS is very heterogeneous. You will see patient with ARDS even from influenza. Some of them have low compliance, some of them have high compliance. And patients who have low compliance, their lungs are very stiff, right? And you will need a much higher PEEP in those patients to open up their lungs. In patients who have a high compliance, so the initial thought process was that those patients have more of blood clots like PE, VTE, microangiopathy. But this is not uncommon in other ARDS as well. That patient will also require a normal ARDS management, but probably will require a lower PEEP. Um, in terms of the mortality rate in ARDS ventilated patient from COVID-19, if you look at different data, you will see from China and Italy, especially from places which were initially very busy, their mortality range from anywhere like 40% to 80%. But if you look at the recent study from Harvard, MGH, and their mechanical ventilated patient, their mortality was 17%. I would say that is probably the same mortality in our institution as well. The problem is that, so why some of the institutions have higher mortality, some of the institutions have lower mortality. It really depends on if they are getting standard ARDS care. Patients, the hospitals and the system which get overwhelmed, they don't get like standard ARDS care. We have seen patients in New York City who are on the ventilator with ARDS on the floor, and many, like some, during some of the days they were not even getting seen by physicians. These ARDS patients need to be assessed by nurses, like let's say every hour, if not more frequent than that. And they need to be seen by physician multiple times during the day. And COVID-19 ARDS usually requires longer time to heal. We have seen these patients on average being on the ventilator for 2 to 3 weeks before they come off. So and that was the problem with most of the system which got overwhelmed, that their patient go on the vent, they have limited number of the vent, the previous patient is not coming off the vent, and next patient needs vent, and that leads to higher mortality. So the system which have full resources, healthcare providers, full PPE, and they're getting standard ARDS care, all the things which reduce mortality, starting with low tidal volume ventilation, proning, PEEP strategy, fluid restriction, steroids. So those patients, and we're looking for ventilator associated complication, all that thing. For those institutions, the mortality is low. So if the mortality is high in any of the institution, I would probably suspect that institution is overwhelmed and not able to provide standard care for ARDS.
Thank you very much, Farrukh.